If you are pregnant or you've recently had a baby, this podcast is for you. I am your host, Kath Bequee, a physiotherapist working in women's health and mum of 3. Join me each week as we dive into all things pregnancy care, childbirth and postnatal recovery, helping you have a wonderful pregnancy and afterbirth experience. And don't forget to hit subscribe so you don't miss any episodes. Well, hello there. Thank you for tuning into another episode of the Fitness to Mama podcast. Today we are discussing all things pain relief for birth. And I have the pleasure of today chatting to anaesthetist Gareth Symons. So Gareth is a dad of 3 young girls and he has been a consultant anaesthetist since 2013. Gareth is trained in a variety of Melbourne and regional hospitals, and he's also been a supervisor of training in public practice and has an ongoing obstetric anaesthetist practice in both public and private health systems, amongst other clinical interests. So in today's episode, Gareth talks us through common pain relief options for birth, and we discuss the use of gas, intramuscular injections, including morphine and pethidine, as well as epidural. Gareth talks us through the benefits and the risks, and we also discuss the impact that COVID is having on pregnant women giving birth. So I do know that pain relief is a very individual choice, but I do trust that today's episode will help you to feel more empowered and comfortable about understanding the different choices available to you, no matter what type of birth you decide to have. So do stick around because this is a great episode in which Gareth provides lots of information to really help empower you with this next stage of your pregnancy journey. Before diving in, I invite you to join us inside Fitness to Mama. So if you have found you are not exercising as much as you'd like to during pregnancy or after pregnancy, perhaps you're busy or you've lost the motivation to exercise, or perhaps you're not sure about how to best be looking after your changing body and your growing belly. Or you've got the pelvic girdle pain and the abdominal muscle separation and you're not sure about the best exercises for you. Or you'd like to get back into running after birth and you want the best Kickstarter. Then Fitness to Mama is for you. So join us for these convenient, short, easy workouts that you can do from the comfort of your home. So head to fitnessmama.com. All right, let's dive into this episode. So Gareth, thank you so much for joining me today on the Fitness Mama podcast. It is great to have you on. We are chatting all things pain relief for birth. So yeah, thank you for joining me.
Oh, no worries. Thank you very much for having me.
So full disclosure for everyone listening, I have been hounding Gareth for a good few months to have him on the podcast. So he is my brother-in-law and it's great. I think Gareth finally buckled. You can't say no to family, right, Gareth?
Absolutely. But I was very, very happy to do it. It's just a matter of finding the time. Summer holidays is perfect.
Yeah, absolutely. So to start off with, what would you say are the most common or popular types of pain relief available for women who are about to give birth?
Look, there's a really wide variety of options for women looking for pain relief in labour. I'd agree with what you said right from the outset, which is that it's a very individual experience and people will have different ideas about what's the most appropriate sort of pain relief for them. Obviously, being an anaesthetist, I'm used to dealing with some of the medical sort of approaches to pain relief, but there are non-medical approaches to pain relief. And what I mean by that are things like relaxation techniques, heat packs, cold packs, water immersion, all sorts of things, which I'm not generally involved with, but which some people find helpful. And then there are the sort of the non-medical, but still, I guess, hospital-based kinds of or healthcare-based interventions, like things like TENS or water injections that the midwives might offer to patients during labour. From an anaesthetic perspective, the things that I guess we sometimes are involved with is providing opiate analgesia, so whether that's pethidine or morphine, right up to epidurals, which I'm sure we'll talk about in detail. But what I would say from the outset is that I know that people will have strong ideas about what they would like in terms of like a birth plan and those sorts of things. And I think that's very reasonable. But I do think it's great that they listen to something like your podcast, Kath, to get some information about all of that before the day.
Yes, being pre-armed and It's amazing that prior knowledge, and it's something I didn't do. Full disclosure, for my first baby, I totally went with the flow, as they say, and I don't think it was a good idea in hindsight. So in terms of what you were just talking about with the different pain reliefs, in your day-to-day practice, what would be the most common?
Generally speaking, my involvement would be when a woman's in labour and in significant distress, usually, because that's why we're asked to attend to put an epidural in most of the time. Most women would be using nitrous oxide at that stage, which is a gas that you can breathe through a mouthpiece, and many women will be familiar with that or will have talked to friends or family that have used that. It's available in pretty much all Australian hospital sort of settings, and that would be probably the most common form of analgesia, I think. In terms of pros and cons, nitrous is fast-acting, works well, take big breaths and you'll quickly get some degree of pain relief with that during contractions, and you can stop breathing it between contractions. So it's sort of something which works well, and that way you can match it with the contractions. Some women find it really helpful. Some women don't find much help at all. And so, again, it's a really individual kind of thing. And you won't necessarily know until you try it. The other thing I'd mention is that it can make you quite sick. We'll stop using it pretty quickly for that reason.
And is that the main side effect?
Yeah, I think so. I mean, there's really no concerns about harm to the baby with nitrous. In the big picture, it's a greenhouse gas, and we look at it from that perspective in anaesthetic practice. But from a labouring woman's perspective, I think that would be pretty secondary in the middle of their contractions. To a labouring woman, I think the main thing would be the nausea, and also just the fact that for a significant proportion of women, it just won't be adequate pain relief.
Is it right that we're talking about these in terms of levels, in terms of easier to apply? So where gas is at one spectrum, and then if the spinal or the epidural is at the other spectrum, is that right, and that gas is at the start of the spectrum of pain relief options?
Yeah. So, I mean, from a medical perspective, the least aggressive sort of analgesic options would probably be just some oral analgesia, which could be as simple as paracetamol, Panadeine 4, those sorts of things. And then those, it would be rare that was adequate analgesia for childbirth, and people would generally proceed to nitrous at that stage. So, yeah, I would say it is a sort of hierarchy. I mean, practice varies from institution to institution and from different settings that women might be having their baby in. But I would say that that's the hierarchy. And then generally, most of the time, if a woman has tried nitrous and has also been offered opiate, so whether that's pethidine or morphine, they might have an intramuscular injection of one of those. If they're still not comfortable or adequately comfortable, then that might be when they might progress to an epidural.
Okay, so let's talk about those injections then. Well, first of all, how long would those injections last?
Well, first of all, I guess onset is going to be half an hour really to start to generate some decent pain relief. And then in terms of duration, like a few hours is the sort of idea. So obviously the duration of people's labour can vary pretty significantly. And so depending on the particular patient, that might be a good option. But if it's going to be a prolonged labour, then it will wear off again during the labour. And conversely, if it's going to be a very quick labour, you sort of, again, would be a little bit concerned about giving a systemic opiate, because there's the chance that the baby comes out a bit sedated with that. So yeah, that's something to consider. Well, something for the doctors and midwives to consider usually, but yeah.
Yep. So when is the ideal time, if you're going to have these options with the intramuscular injection, when's the ideal time for that to happen?
So I would say it would be, once labour has properly commenced, the patient's having contractions, they're uncomfortable. You don't really want to do it before that, but early in the labour. So, you might be just starting to dilate at that sort of phase of labour rather than sort of waiting until you're getting close to delivering.
Okay, so you're saying you don't want it to be in the system during the pushing phase?
Not so much that it can't be in your system, but you wouldn't want to be administering it close to the end of the labour.
Okay. And what are the potential side effects?
So I guess the side effects could be either for the mother or for the baby. And what I'm most concerned about side effects for the baby in that setting, in terms of the baby coming out a bit sleepy. I should put some context to that. If you're delivering in a healthcare setting where there are paediatricians and so on available, it's not a huge concern, but it's just something to be mindful of, and something that we'd be mindful of and the midwives would certainly be mindful of. And then in terms of side effects to mum, again, it's a little bit like nitrous in that respect. You can get nausea and or vomiting. You can sometimes get itch with it as well. Of course, some people have allergies to specific types of opiates like morphine. Some people won't tolerate very well, but primarily nausea and vomiting, I'd say.
And how common are they? Are they commonly used?
Oh, yeah. Yep. Still relatively commonly used. Yeah. Often women who are requesting an epidural have already had intramuscular opiate before the epidural request.
Yeah, that makes sense. And do you also, for those women who, for whatever reason, are wanting to avoid an epidural, are they the ones that are more likely to perhaps do those intramuscular injections?
Yeah, look, I'd say absolutely. But as you know, Kath, like some women will come in with a birth plan, which is really to minimize analgesia, absolutely. And that's, of course, absolutely their call, and maybe trying to avoid everything. Some women will come in with a plan where they're sort of happy to use nitrous, but hoping not to use much more than that. But I do think that some women will be happy to try everything short of an epidural because of concerns they've got about an epidural. But once those options have failed, then might progress to requesting an epidural at that time, yeah.
Okay, well, that leads us perfectly into the next question then, epidurals, because I know it's a bit divisive. So let's go for it, Gareth. What are the benefits of an epidural? And let's also go through the risks as well.
Yeah, so I want to acknowledge that there will be plenty of people who don't want an epidural, and that's absolutely their call. But I guess I'll present what I see as the pros and cons. From a medical perspective, epidurals are the most pain relief, the best pain relief that you can have during childbirth. They're the most effective interventions that we can provide to relieve pain. And certainly from a doctor's perspective, it's a really satisfying thing to help someone with, because you see someone who's in really significant pain and achieves really good pain relief, potentially complete pain relief, within the space of sort of 20 minutes to 30 minutes from the time they've called you to the time that they're completely comfortable. So the major pro is that you get excellent pain relief with it most of the time, not all of the time. And then, look, there are some other potential pros. There are medical reasons why sometimes your team might recommend that you have an epidural. For example, women with preeclampsia, it may be suggested that they have an epidural, which will help with their pain relief, but also help us manage the different phases of the delivery, including if they were to need to go to cesarean section. It's a really good way of providing anaesthesia for the cesarean section.
And can you explain that a little bit more for those listening? So how can an epidural help if you need to have a cesarean?
Yeah, so if you're going to have a cesarean section, which is essentially, making a cut in the tummy, like it's what we would call a laparotomy in medical terms. It's making a big cut in the tummy to deliver a baby. It's a big ask, and we need to provide you with really good pain relief to make sure that the woman's able to deliver that baby in comfort. An epidural involves putting a little catheter into this space called the epidural space around the spinal cord. And because we leave a little catheter in there, we can actually use that catheter to provide a stronger form of pain relief, which facilitates doing the cesarean section if it comes to that a woman needs a cesarean section, or that that's the appropriate way to go. The nice thing about that, as opposed to any of the other forms of pain relief, is that you are ready to go if that was needed. But it certainly doesn't mean that you're going to have a cesarean section. And I know that a common misconception that people have is that having a epidural means that you are going to have a cesarean section. From an evidence-based perspective, there's no evidence to suggest that you have an increased risk of a cesarean section if you have an epidural.
Okay, that's great to know. So you're saying if you have an epidural, there's no increased risk of cesarean birth?
Correct. But it does mean that if you did need a cesarean section, then you've got a way to provide anaesthesia for it already ready to go.
Could you just talk us through, just in very quick general term, what is the process of getting an epidural? Like, what does a woman have to do?
So the process of getting an epidural involves an anaesthetist attending. So you need a specialist doctor to attend. Usually the midwife or nurse looking after you or carer looking after you will request the anaesthetist to come for you. And things that would need to be done usually involve getting some basic blood tests done, particularly if there's any concerns medically about how things are going in the labour, and also just getting what we call IV access, so putting a cannula into one of the veins in your hand or arm and starting some intravenous fluids through that. And I'll explain why we do all of that in a moment. Then following that, usually the anaesthetist would attend hopefully pretty quickly. Usually at that stage you'd like them to attend quickly, and they'll explain the epidural to you and risks and benefits. And this is why I think it's great to go through some of this now, because it's very difficult to take that in the moment between actions. And then once the anaesthetist has gone through the risks and benefits and explained that to you, they would fairly quickly get things set up. So It's a technique which we perform as a sterile technique with aseptic sort of practice. So we're really trying to minimize the risk of any infection in what is a really important part of your body in terms of being close to the spinal cord. The anaesthetist will unpack the equipment in a sterile way, making sure there's no contamination of the equipment. They'll get you sitting up on the bed, and the way we actually find the right spot for the epidural to go in is by palpation. So have a feel of the patient's hips and their back, put some antiseptic on the skin just to make sure there's no bacteria remaining there, and then put some local anaesthetic in the skin with a small needle to make the skin go numb. And once that skin's gone numb, then we can use a large needle to actually put the epidural catheter in without it causing any sort of pain in the skin.
This episode is brought to you by Baby Bee, Australian-owned and designed prams combining quality, safety and style. Not only does Baby Bee let you try their prams at home with free returns for 9 months, yes, that's 9 months, they also offer an industry-leading 3-year warranty for total peace of mind. With thousands of 5-star reviews, around-the-clock customer care, and up to $300 of free accessories with every pram, what are you waiting for? Go visit www.babybeeonline.com and check them out for yourself. And yes, for listeners of the podcast, there is a 20% discount code. Enter FITBEE, FITBEE 20 at checkout, and T's and C's apply. Oh, I didn't realise. Of course that would happen, but I thought that first needle was everything happening.
Yeah, that's a good point, because I think sometimes people think that there's been lots of goes, in quotation marks, to put the epidural in, but actually that's just a part of the process, is to numb the skin with local anaesthetic first, because the epidural needle, it's not one I'd advise the woman who's in labour to turn around and look at. It's a relatively big needle, but it really doesn't hurt because the local anaesthetic has already numbed the skin, which is where all those nerves are that can make it uncomfortable.
Yeah, right. Good to know. So what happens once that bigger needle's gone in?
Once that needle's in the right spot, we then feed a little catheter through it, and that catheter sits in the epidural space, and we're then able to load that up with local anaesthetic to block the nerves that are supplying that part of the tummy, where the uterus is and where all the pain's coming from during childbirth.
Yeah, great. And you mentioned that takes so once the needle's gone in, how long until the pain relief starts to kick in?
The pain relief starts nearly with the next contraction, but for it to really achieve effective pain relief, it probably takes 3, 4, 5 contractions. And so that might be 10 or 15 minutes for it to be complete sort of pain relief. And I should say it doesn't work perfectly for everyone. Not every epidural that goes in works really, really well, but they probably do roughly sort of 8 or 9 times out of 10 work very effectively. And when they do, it can be complete pain relief.
And what about those 1 or 2 out of 10 when it doesn't work?
It's not uncommon for example, to get a block on one side but not on the other. So you might have a block on the left side of the tummy but not on the right side of the tummy. Sometimes if the baby's not in the optimum sort of lie, you might still have some sort of breakthrough pain in the back, or certainly as the labour progresses and the baby's getting close to being delivered, there might be some perineal and sort of vaginal pain that breaks through the epidural as well. There's a number of different sorts of nerves which you need to numb at different stages of that labour.
Yeah, okay. So Gareth, I would like to also ask you about the different types of blocks, because I have heard a few women recently who they had an epidural, but they still had quite a bit of sensation when it came to, and that's what they requested. They wanted to still have quite a bit of sensation when it came to giving birth.
Yes, absolutely. So I think epidurals have changed over the years, and certainly historically people used to take a bit of a sledgehammer approach to it and use a really high concentration of local anaesthetic in an effort to really achieve complete pain relief. And it was probably quite effective at that, but at a cost of potentially increasing the risk of instrumental delivery and also causing really significant motor blocks. So the legs of the mum really can't move at all. And then it might be really difficult to feel any contractions whatsoever. historically, so over time that's changed, and people use a lower concentration of local anaesthetic generally now than was done in the past. There probably are some differences between individual practitioners in exactly how they do the epidural these days. And I think there is a room for a labouring woman to ask the anaesthetist if they can go slowly with the epidural, for example, and not sort of load it up too aggressively if they're sort of hoping to get pain relief without a really profound block. That said, I've sort of heard of people advocating walking epidurals, things like that. Personally, I don't think it's a great idea. I think if you've got abnormal sensation in your feet and your legs, and you may have some weakness in your legs, that sort of puts you in a position where you might not be very safe. And the other thing which we haven't mentioned, I should have mentioned, is that usually, and certainly at the institutions where I've worked, a woman would have a urinary catheter put in when they have an epidural put in, because they won't be able to feel the sensations of their bladder filling the way they usually would. And that just allows the bladder just to empty and not have any trouble from that.
Okay, so to just back up and dive into what you were talking about, the walking epidural, are you referring to when it's not so much pain relief that a woman can still move her legs and still walk?
Yeah, so because we use much lower concentrations of local anaesthetic than we used to, there's a really good proportion of women who can still move their legs pretty well, even once the epidural's on board and they may be getting pretty good pain relief. But in my mind, that doesn't mean that you should be walking at that point.
Okay.
Once that local anaesthetic's been loaded in, your sensation's not going to be normal in your lower limbs. And it's hard to assess whether you've got a small degree of motor block you're not sure about, or you haven't really detected, and might not be very safe to get up and walk around.
Yeah, okay. Good to clarify. Are there different names, just so that if women's talking about one, concentration of epidural versus another, apart from walking epidural, is there another name that is used?
I mean, I've heard anecdotally friends talking about light epidurals and things like that. From an anaesthetist perspective, no, we don't have a sort of a variety of epidurals that we put in. We basically put in, well, certainly in my practice, I'd put in the same epidural for anybody. I would at times might load it up slower if someone tells me that they're really keen to just get a degree of pain relief and that they really want to try and make sure they can still feel their contractions really well. And I'm happy to go slower if that's what someone wants. But there's not really different types of epidurals that an anaesthetist would identify as different.
Okay. Yeah, that's good to know. So I'd love to ask, because I know this is a question that comes up a lot with the women I work with, is do you have to birth on your back if you have an epidural? Or what are some other options available in terms of positioning for a woman if they have an epidural? Can they be on their side, for example, with the use of a pillow under their leg?
Yeah, I think that's a really good question. And to be honest, I'm not usually there at that part. But from a technical perspective, there are some challenges. The local anaesthetic will tend to be distributed to where gravity distributes it. And that means that immediately after we've put an epidural in and loaded it with local anaesthetic, we would want a woman to be relatively flat, just to ensure that she gets pain relief on both sides of her body. Once you've sort of achieved good pain relief, then there's no reason why she can't go on her side. Absolutely not a problem at all. The only downside that I can conceive of is that the more moving around that you do and changes of positions that you do, the more likely the epidural catheter will be pulled out. And it does happen from time to time, but we're certainly aware of that risk, and we tape them in pretty securely, knowing that there's a chance it might get pulled out. So there's no reason you can't move around, in the bed.
Yeah, interesting. Okay, well, that takes us beautifully onto risks. So what are the risks of an epidural to both the woman and her baby?
Yeah, so the way I frame this discussion is common sorts of things that can happen, and then the really rare sorts of things that can happen. So common sort of issues, we mentioned before that some epidurals, when they go in, just don't work as well as we would like them to. And that may be as much as 10 or 20% of epidurals that go in, to some extent, don't provide the degree of pain relief we would like. Other things that can happen relatively commonly are a sort of drop in blood pressure. And that's one of the reasons that we have that fluid running through an intravenous cannula before we even put the epidural in. And it means that we can give medications if we need to normalise that blood pressure really quickly. And you would notice the midwife looking after you would be checking your blood pressure really frequently after an epidural is inserted for that reason. that we know that that's a possibility. And then the other relatively common, it's about a 1% risk is a post-dural puncture headache. So that's something which doesn't usually occur during the labour, but in the days afterwards, sometimes women develop a postural headache, which can be quite severe and can sort of require intervention to sort of sort out in the days after the baby's been born. So that's, I guess, uncommon. You're a 99 chance out of 100 of not getting it, but still, we see quite a lot of people with that just because of the huge numbers of people having babies.
Yeah. And does that tend to disappear by itself after a few days, or
so
is there any special monitoring that needs to happen?
Not monitoring. We monitor people clinically, I guess. We talk to them and see how they're going, and we'd offer sort of simple pain relief. We'd offer caffeine, which is a relatively effective treatment for post-dural puncture headache. There are some procedural things which can be done. And if none of those simple sort of things work, then you can be offered what's called a blood patch, which is where an anaesthetist would take some blood, in a really clean fashion from your arm and then inject that actually into the epidural space, the same spot where they did the epidural in the first place, and it just seals up the leak of CSF, which is the fluid causing the headache, or the leak of that fluid is causing the headache. That's really effective. But if we do need to do that, obviously there's a reason why the person had a dural puncture in the first place. Sometimes it's because it was quite difficult to put it in. And also there is a risk of recurrence of the headache recurring even after that blood patch. So most of the time we would try and manage it as you sort of suggested. We'd give them some pain relief and hope that it resolves, and often it would. Yeah.
Yeah. Okay, good to know. When you mentioned before there is a risk, like if you're moving around the bed, that what do you call it, the needle falls out?
The catheter. Yeah, the catheter.
Epidural catheter. Yeah, if that falls out, can you then reinsert it, or is that no more epidural?
No, you can. Sometimes if that first insertion that we do doesn't work as well as we would like it to, we might repeat it and just do the procedure again. There's no problem with doing it for a second time. And if the epidural catheter does fall out during labour, yes, it can be repeated. It depends a little bit on the setting, how quickly that might occur, and depending on the progress of the labour, if the baby really is sort of on the way out, it may not actually be a good time to try and do it.
Totally understandable. Okay, so let's move on to the rarer potential risks.
Yeah, so the things that people worry about, and understandably worry about, are injuries to nerves in their back, and certainly something that we have top of mind when we're putting epidurals in. The chance of a nerve injury with putting an epidural in is very small, and that's 1 in thousands. The chance of a nerve injury that doesn't get better and causes weakness, which doesn't resolve quickly after the epidural has come out, would be 1 in hundreds of thousands. So because it's so rare, the numbers are a little bit hard to pin down, but somewhere between 1 in 100,000 and 1 in 250,000 of having a really severe complication from an epidural in terms of weakness or even paralysis, which is obviously a horrific side effect to occur, but incredibly uncommon.
Yeah. And I'm putting you on the spot here, but is that stat for Australia or more worldwide?
It would be in Australia and hospital systems like Australia's, yeah.
Yeah, okay. Would you say that's the main risk to mum, the biggest rare risk?
I guess the other things which could happen very rarely, sort of meningitis is another one. So you get an infection in the central nervous system from, anytime we put a needle into the body, there's a small chance of introducing some bacteria. That's why we do it in such a clean fashion. Yeah, epidural abscess, so an infection out the side of where the epidural went in. And the other one is an epidural hematoma, where there's a blood, some bleeding and bruising around where the epidural's gone in, which again can cause nerve injuries. We worry about those things. But all of those things, the abscess and the hematoma, the main thing we worry about is injuries to nerves in that setting. Yeah, I think that would be about it. Yeah.
Okay. Now, how about is there an increased risk of instrumental delivery with an epidural?
Yeah, that's a really good question. Traditionally, we've always thought that there was. Right now, there's probably some conflicting evidence, recent evidence saying that perhaps because of the reduction in the concentration of local anaesthetic used in epidurals, that there may not be an increase in the risk of instrumental deliveries. It's hard to be absolutely sure, but there possibly is an increased risk of instrumental delivery. So if that's really, really important to somebody, then that might form part of their decision. it's hard to tease out. There's lots of things going on during labour. We know there's no increased risk of caesarean section. Instrumental delivery is a little bit more nebulous and probably on the improve as people continue to use lower concentrations of local anaesthetic in their epidurals.
Yeah, it's interesting. And obviously being a pelvic floor physio, I do see a lot of women with pelvic floor issues. So and as you said, there's so many factors. So it would be really hard to research to see what the causative factors are of, for example, pelvic floor dysfunction as a result of forceps, which is as a result of an epidural. It's really hard to, it would be really hard to research that.
I should say as well that whilst everyone's worried about the risk of having a nerve problem from having an epidural, what we actually see in practice more commonly is women with either sensation changes or weakness in their legs, which is actually due to a nerve injury during delivery of the baby. So the baby actually causing a nerve injury on the way out of the vaginal canal. But usually those things are sort of pretty self-limiting and get better on their own.
Yeah, that's a good point. Are there any, just to finish off the risks, are there any risks to the baby with the epidural?
No. So look, I would say the epidural is very safe for the baby. So the medicine which is put in through the epidural catheter is really limited to the epidural space. So the baby doesn't see any medication from the epidural, which would be different. For example, if the woman was given systemic opiates, obviously they can get to the baby. Very occasionally, you might see a change in what's called the CTG, which is the monitoring of the baby's heart rate soon after an epidural is put in. Whether that's related or unrelated, sometimes hard to know. There's theoretical reasons why sometimes things might change after the epidural has gone in, and just the fact of relieving pain can change the way things are going a little bit during the labour. But no, I would say very safe for the baby is the way I would describe the epidural, yeah.
And we were discussing off air, there's been some recent research talking about the epidural. Do you care to share what that, in general terms, what that research was referring to?
There's a lot of research being done on epidurals in childbirth all the time. And when there is so much research being done, I think there's pretty variable quality of that research. And whilst there's sometimes things which are reported in that research that could sound scary, I think it's probably best to talk to your doctor or to the person looking after you during your pregnancy for sort of clear information that sort of has some context. So I probably wouldn't go into detail about sort of the different publications which come out because sometimes they're hard. It's hard to give context to those studies. Yeah.
Yeah, and we'd need hours to discuss them as well. And that's great advice, Gareth. So anyone listening today, if you've read something or heard something, go and have a chat to your healthcare provider. And yeah, it's really good advice. Thank you, Gareth. So to finish off, and again, I'm just throwing this question at you, to all the women listening, if they're thinking about their pain relief options for their upcoming birth, what advice would you give them to a pregnant woman here listening today?
Yeah, first of all, I think well done for thinking about it now before you come to deliver, because I think it's absolutely the right thing to have just considered these things before you're in the moment in what can be really quite a painful experience for some people. Beyond this conversation, I think that there are some fact sheets put out by some of the healthcare networks and the hospitals, particularly obstetric hospitals like the Royal Women's in Melbourne, for example, which you can probably put in the show notes if you need to, which go through the risks and the pros and cons of different sort of forms of pain relief. I guess from my perspective, I would encourage people to be open-minded. You should absolutely make a plan that's right for you. But from my perspective, I think having a degree of flexibility in that plan is a good idea because it's hard to know what it's going to be like until you're in the moment. And so even if you feel like maybe an epidural is not for you, for example, and that's totally fine if it's not, I'd still educate myself about it and try and find out a bit about it before I come to deliver. That would be my advice. Yeah.
Gareth, before we wrap up, I had one more question considering the current climate. So at the time of recording, the COVID saga is continuing, but it's really impacting the hospitals, and I think it's great to talk about. Has COVID affected the way you work at all and the pain relief options you're able to provide women in hospital?
Yeah, absolutely. Without a doubt, it's affected the way we work. But I'd don't think it's affected the pain relief options that we're able to offer. At the moment, I can say as of January 2022, where I work, we're seeing a lot of pregnant women with COVID, and their pain relief options are exactly the same as they've always been. They're still able to get an epidural. We ensure that we do that in a safe way for the patients and their family, and also for us and for the other staff. So we can use PPE or personal protective equipment to make sure that everyone's kept safe. The pain relief options are the same as they've always been. It can be a little bit more complicated in terms of arranging like cesarean section deliveries, and there can be some medical complexity on that side of it, particularly if women are unwell with COVID. And I should take this opportunity to really advocate for vaccination in women who are pregnant or planning pregnancy, because we know that they are at increased risk of really severe COVID. So I would absolutely advocate being vaccinated. We know that there's no harm to the baby, and there's huge amounts of evidence to support that. But in terms of pain relief, same options as normal. The cesarean section can be tricky. I would try not to worry about that and leave that up to us to work it out. The only other thing, which I guess is particularly impactful on women in what is a super important part of their life, an important event in their life, is about who they're able to have with them. Obviously, having a child is an important event in people's lives, and we would like them to have the loved ones with them that they would like. Sometimes, depending on the situation with COVID at the time when they're delivering, it may affect who can be there and for how long. But I know that hospitals are trying their very best to make sure that the partners are facilitated in being there for as long as they want to be there and all of those things. But obviously there'll be examples when it's not the same way as it would have been prior to COVID.
Yeah, okay, great. Well, thank you for clarifying that. And hopefully this episode is reassuring to women out there who are considering their choices and trying to navigate having a baby in this current COVID climate. So thank you very much, Gareth, for coming onto the podcast. I really do appreciate it. And before I sign off, remember my team and I will be putting together the show notes for this episode with all the links at fitnessmama.com/podcast. And also, if you did enjoy this episode, let me know on Instagram and come and send me a DM, a message. And my Instagram handle is @fitnessmama. So have a fabulous day, everyone, and I look forward to you joining me next week for another episode of the Fitness Mama podcast. Thanks for listening to the Fitness Mama podcast, brought to you by the Fitness Mama freebies found at www.fitnessmama.com/free. So please take a few seconds to leave a review, subscribe so you don't miss an episode, and be sure to take a screenshot of this podcast, upload it to your social media, and tag me at Fitness Mama so I can give you a shout out too. Until next time, remember, an active pregnancy, confident childbirth, and strong postnatal recovery is something that you deserve. Remember our disclaimer: materials and contents in this podcast are intended as general information only and shouldn't substitute any medical advice, diagnosis, or treatment. I'll see you soon.